welcome to PsyTech's webinar on teen depression and anxiety. I'm Dr. Erica Steinbrenner. I'm a psychiatrist in Chicago at APS Ketamine Wasana. I'm very excited to be serving as the moderator for today's discussion. I'd like to begin by briefly introducing our panelists, and then if each of you wants to just spend a few minutes talking about your work and your background, that would be wonderful. So we'll start with Dr. Aguirre. Dr. Blaise Aguirre is a child and adolescent psychiatrist. He is a trainer in and specializes in DBT, as well as other treatments such as mentalization-based treatment for borderline personality disorder and other conditions. He's the founding medical director of 3 East Continuum of Care, which is an array of programs for teens that uses DBT to target self-endangering behaviors. He's also been the staff psychiatrist at McLean Hospital since 2000. Dr. Aguirre is the author and co-author of many books, including Borderline Personality Disorder in Adolescents, Mindfulness for Borderline Personality Disorder, Coping with BPD, and Fighting Back. Welcome so much, Blaise.
Oh, thank you so much. Happy to say something now or wait for you to finish.
Yeah, a few minutes now would be wonderful. Yeah.
Yeah, awesome. Yeah, so I'm very interested by the teen suicide because it's one of those just terrible tragedies that we're seeing an incredible increase on. And I historically was very dissatisfied with the treatment approaches that involved either just simple traditional talk therapy or medications, which didn't seem to work for the patient populations that I was working with, and really wanted a very new approach. And so in 2007, I started a program for kids who were very suicidal. And we've now had about 4,000 kids come from all over the world, China, Japan, Australia, New Zealand, the Middle East, North and South America, Europe. And all we do is work with suicidal teens and use dialectical behavior therapy to treat them. And when that doesn't work, which nothing works for everything, refer them on. And my preference is to refer kids on for alternative methods rather than standard pharma.
Thank you. Our second panelist is Dr. Tapan Parikh. He's the medical director of acute care services at Ann and Robert H. Luthery Children's Hospital in Chicago. He's also assistant professor of psychiatry and behavioral sciences at Northwestern. Dr. Parikh completed his child adolescent psychiatry fellowship at Ann and Robert H. Luthery Children's Hospital. In addition to his formal training, he's completed a 3-year intensive program in psychodynamic psychotherapy at the Psychoanalytic Center of Philadelphia. Dr. Parikh's published several peer-reviewed journal articles and regularly presents posters at various national meetings. Tapan, thank you so much for joining. Can you speak a little bit about what you do?
Yeah, thank you so much for the kind introduction and having me here. I am, as you mentioned, I'm working at Luthery Children's Hospital here in Chicago, working exclusively for children, adolescents, and almost everybody under 18 on our acute care services, which includes many services, but I primarily work on 2, which is inpatient unit and partial hospitalization program. So we get to see very high level of the acuity and just kind of the presentation, including the suicidal ideations, thoughts in teenagers, which is just much more severe than just community and outpatient kind of the practices. But we are a short-term psychiatric facility, and after our management, there might be just the other needs, and then transfer the kids to just the other kind of the settings, if whatever would be the appropriate kind of the next level of care. In the pandemic time, we have seen gradual increase in all kinds of just the difficulties for teenagers, and one of those is just the suicidal thoughts and the amount of depression and just the difficulty to treat depression that has been just really striking in the past few years, that we have tried multiple things, nothing has worked, and we need to keep getting these kids better and get them back in their just kind of the life trajectory. that's what just excites me about this current talk and like talking about like what do we do when we enter into this zone of like this very challenging kind of the clinical picture.
Thank you. This is very true. Well spoken. Our last panelist today is Dr. Mark Bronstein. Dr. Bronstein is a child, adolescent, and adult psychiatrist with 3 decades of clinical experience, including his pioneering work integrating wilderness, nutrition, and plant-based medicines. He's a sought-after medical consultant and educator for his mental health cannabis dosing protocols. His current projects are focused on expanding awareness, research, and safety in psychedelics through his company, Reconscious Medicine. Dr. Bronstein, it's great to have you here.
Thank you. Glad to be here. Yeah, so I've been a psychiatrist for a while. I was trained in classical psychopharmacology as the main approach to treat depression, anxiety, all disorders, right, in children, adolescent, and adults. And not long after getting into my career, started realizing that maybe this wasn't the answer. It wasn't combinations of different medications. And I learned this largely from my patients, not from my training, but from watching my patients and watching them go away to hospitals, come back on these combinations of medications after just a couple of days in the hospitals for suicidal ideation, and they weren't getting better. And around that time, not long after I started my career, I started working in the wilderness. And the wilderness setting, it was basically residential treatment, 90-day treatment programs, but in a wilderness setting. And over that time, I was taking people off of medications. And I was watching them leave happy and beaming. And in my experience, in my training, no one left a hospital beaming unless they were still manic, right? So it's like they were there for 90 days. They were coming off of their medications. They were eating right. They weren't using substances. They weren't in their dysfunctional relationships with their family or peers, and they were doing great. So, you know, it had me thinking, what are some other things we can do besides, maybe the answer isn't these combinations of medications, and maybe it's these combinations of medications actually causing symptoms, causing people to get worse. Maybe it's causing suicidality, right? So focusing on wilderness therapy, DBT, other kinds of therapy, but really focusing on therapy and really utilizing medications to augment psychotherapy, right? And so that's been my focus with psychedelics, has been using psychedelics to augment psychotherapy. And a lot of that was from, I'm not just a psychiatrist and a psychopharmacologist, I'm also a psychotherapist. I spent over a decade with the same people on the couch, like watching some people just not get better, not transcend, not transform. And that's where psychedelics come in. And it's little intervention with psychedelics can really greatly accelerate psychotherapy.
Yeah, definitely.
I could keep going on and on and on, but maybe I'll wait till we have more questions and stuff.
We'll get into it a little bit more. Yes, yes, thank you. Well, I think, you know, teenage depression and anxiety is such an enormous topic, and we could spend hours talking about just one part of it. So obviously not going to do that today. What I'm hoping to do is really just kind of have an overview and kind of scratch the surface of, you know, what can we do with these things that these points you're bringing up, which, you know, the current treatment models are just not sufficient for so many people, and whether that's ketamine or not, what options are, what does the future potentially look like? So I do want this to just kind of be an organic discussion. So I'll direct questions to each of you guys specifically, but feel free to jump in and talk to each other as well. And also our audience, as you can see, you got a prompt in the chat to write in some questions. So if you have some, you know, things that you'd like to have the panelists talk about, feel free to type that, and we'll try to get to those definitely. So let's start things off. Just, you know, stepping back a little bit, the large picture. We'll start with you, Dr. Aguirre. When you look at children and adolescents as opposed to adults, are there additional or unique components that you need to take into account when you're looking at treating them versus an adult population?
Yeah. Just a couple of things. There was a fantastic analyst, Winnicott, who said there was no such thing as an infant. And what he meant by that is that an infant cannot exist on its own, that it's part of a larger system. And, you know, so that teens and adolescents, it's not that they grow up in isolation. There's an interconnectedness between themselves, their parents, their peers, and now their social networks. And, you know, and these influence powerfully. And it's bidirectional or tridirectional. And so, you know, one of the things that I really like what Mark said, you know, kids come in and say that they're depressed. But, you know, English is such an imperfect language. And what the heck does that mean, depression? You know, and so there's a dissatisfaction with life. There's an existential disconnectedness versus something that is very, very vegetative. And so one of the things in terms of thinking about depression is that you cannot think of depression in isolation. You have to think of it contextually. The second thing is that we don't tend to listen that much, I don't think, many of my colleagues psychiatrists, to what some of our patients are saying. So similarly, I see lots of kids coming on lots of medications, and the kids have said, these aren't working for me. But then what happens is, well, you know what we need to do is we need to increase one, or we need to add something else. And so what happens is that rather than saying, hey, they're not working, and taking them off. And just the third thing is this. It's very interesting when I hear colleagues talk about depression and they talk about their kids. They say, you know what I'm going to do is I'm going to take my kid for a walk. I'm going to go for a run. I'm going to go and do something. But then a patient comes in and they said, I'm depressed. I say, okay, here's a prescription. So the idea of just listening, the idea of really distilling down what depression is in these kids is very powerful. And just one last thing, I do write prescriptions, sometimes for medications, but I often write it for mindfulness practice or for walking practice. They say, I want a prescription. I said, here you go. And they say, what is this? Mindfulness. What is this? Exercise. What is this? Eating. Because we know that those foundational elements are so important in the treatment of depression. But I did say it was my final point, but one other thing is, when these things don't work, none of these, I do want to think about, you know, when somebody's acutely suicidal in an emergency room, rather than hospitalizing, rather than putting on medications that aren't going to work, is to think about some of these other alternatives, you know, like psilocybin, ketamine, and others, TMS, that do seem to be quite helpful in acute situations. So also beginning to integrate these other ideas for children and adolescents.
Yeah, definitely. I liked all those points. Kind of going back to that, the first one, which is, you know, contextually, you have to step back and look at the whole picture. Do you see that there is the limitations of getting kids to a treatment that is more holistic, whether that's wilderness or whether that's, you know, mindfulness or whether that's a DBT program? Do you see that as more of a societal parental thing that they can't get the kids to the right place? Or is it parental, or is it like societal in terms of like the structure of care, the way it's set up in the United States? And I'll give that question, go ahead and answer, or Dr. Parikh too could jump in. You also are worked in sort of more of a medical, you know, typical setting in the US. Dr. Parikh, sorry.
Yeah, sorry. Yeah, so do you mind like just rephrasing the last part? Yeah.
Sure. So I think we have all agreement, or Mark and Blaise have alluded to, you know, these mindfulness or other approaches, or seeing kids outside of, you know, the medication model. Are you seeing, you know, do you think that not getting enough kids into the more holistic, you know, approach for their treatment is due to more parents, or more due to sort of the system's not set up, there aren't DBT programs, or there aren't places to match kids? Or
Right. So so we do see like just all kinds of like just the spectrum of like just the difficulties in terms of the depression. What we are focusing on in this talk is like just the complicated, or like just sometimes like just not getting better after we tried all the initial things. So initial things are very basically just trying one of the medications which are approved for anxiety or for depression, we start with that. And we definitely want psychotherapy as the very first line kind of the treatment. And I can't imagine anybody being on just medication and not having any amount of the therapy, as the medication alone is not going to be enough. And we depending on like just the condition, like we do see the response. We do see them getting back on their trajectory of like just going back to school, getting motivated to do things that they weren't doing. So inpatient unit tends to be like really short, and we barely get to do anything. But on a partial hospitalization program level, where we have daily 6 hours of intensive treatment, we do focus on like just the CBT based kind of the principles, and follow one of the treatment modalities called unified protocol, which is also like based on the CBT principles, and guiding like just all the teenagers with like just the kind of 6 hours of day, kind of the daily treatment. And that sometimes helps also. So these are like just really initial kind of like just the options. And then when we don't just really see any response, then it becomes challenging. That like where do we refer? Then there are like these DBT specific programs, or like longer term, like even our partial hospitalization is few weeks. We're not talking about 90-day program. So those might be like just the more appropriate for some of the patients. And going into the holistic kind of the model, and I know we will probably talk about like just more of the ketamine also, and like just what role like just in general the newer medications could play. I'm just going to comment briefly in a simple language about like just the evidence-based kind of the treatment model, that like we put something into research framework, we see that whether it works, and when there is some data that like okay it works, that's when like just we would be prescribing, and we would be like suggesting that like go for that. So like we do want to probably, I mean, again, I'm not saying that this is the best possible way for like just every single person, but if we follow this like standard model of like starting with what we usually do and going on the path of like just probably being innovative and eventually being holistic, this is kind of the normal trajectory. And I don't mean that that's the ideal kind of the trajectory. But even the holistic, that like I would want to like just encourage everybody to like generate the evidence which goes into the mainstream kind of like just the publications and the research kind of the pipeline and the framework, so that we are very confidently and comfortably able to continue to suggest some of those.
Yeah, those points. So to that point, thank you so much, by the way. Dr. Bronstein, so you actually have sort of jumped ahead a little bit of the curve and are using additional tools in addition to the DBT and the traditional things we have typically available in the medication or the medical model in the US. What kind of responses are you seeing with kids with these, with ketamine, with cannabis, I believe you use as well?
So I cringe a little bit when I hear about the data and about really following the data, because as I've seen psychiatry over the last several decades get more towards an evidence-based model, I've also seen rates of mental illness and suicidality in teenagers going up, right? So we have this push on evidence-based medicine telling us to go through these treatment algorithms with psychopharmacology, but what I've witnessed is that not really working. So it's been kind of confounding, right? Because we have the data showing that adding an atypical to the antidepressant is going to help. But like clinically speaking, when I'm sitting with kids and adolescents and I'm asking them, what does this medication do? Is it helping you? They don't really say yes much, except for their stimulants that they're addicted to. And that they can very much tell you they're working and they can't concentrate or they don't have energy. It kills me when a 15-year-old tells me they don't have energy and they need this medication for energy. I'm sorry, I got a little bit distracted with the question, but I wanted to get back to that. And then we don't have the evidence yet for psychedelics or for ketamine or for cannabis, but what I'm seeing is that they're working. What I'm hearing is that they're working. And the one thing that I really most agree with in psychiatry was listening to my patients. So when I ask them about their Prozac or their Ritalin or their Abilify, I would listen to what they say. And I would make my next choice clinically on what they said or what was observed, right? But we don't do that with cannabis. We don't listen to it. We don't listen to our patients about cannabis. If they're telling us this is working as a mood stabilizer, we should listen. If it's helping with anxiety or insomnia, I think we should listen. So we should treat cannabis, ketamine like other medications we have, and not just dogmatically not listen to something because we were taught it was in the category of a drug of abuse. If someone is telling us that their venlafaxine has helped with their venlafaxine has helped with anxiety, shouldn't we also ask someone about their cannabis? And then with ketamine, for instance, you know, the idea that I can treat someone a half a dozen times and get them past their major depressive episode, when combining that with therapy, give them a whole new schema to go through life with, right? So you can really it's my favorite group to treat with ketamine is adolescents and young adults, because you can make such significant change early in one's life, not just on a biological level with the medication, but psychotherapeutically and spiritually. You can just get someone started on a whole nother direction of wellness much earlier. I'm going to stop myself.
That's a good point. So are you traditionally in your practice doing the typical 6 sessions, or how are you utilizing ketamine and cannabis?
Yeah, so typically I like to use it in a 6 treatment burst the first time I'm going to treat someone with it, which will hopefully be the last time I'll treat them with it as well, right? So it's very interesting and different in psychiatry when they come in and I'm like, all right, we're going to do this, and hopefully you're never going to have to see me again, right? Like they've never heard that before in psychiatry. It's more like you're going to come back and you're going to see me forever, once a month, forever. So it's a much different paradigm. And yeah, and as far as suicidality, like the amount of time that it takes to treat someone of their suicidality, we can get someone through it so quick compared to the risks and dangers of taking an extended period of time, utilizing different medications, some of which can actually increase suicidality in teenagers especially, right? So it's like, if you have to make a decision, well, what's better? I can do this 6 times and hopefully not have them on medication for the next year, at least. Like that seems to be the better choice. And so I'm going to really make the argument here that we should consider utilizing ketamine specifically as first-line treatment for depression in adolescents and young adults and kids. Yeah. We shouldn't wait. It shouldn't be only for treatment resistant. It shouldn't be after they've failed and struggled miserably through multiple medications. That shouldn't be the route that this goes, when we have something that we know can work in a couple weeks.
Dr. Parikh, you know, what evidence is there for ketamine? So we're talking about, you know, it's a newer thing, and you have a great point, Mark, that, you know, often trials are way behind, you know, what's needed, and they're flawed, you know, anyway. But Dr. Parikh, I know you did a wonderful editorial last year for American Journal of Psychiatry and kind of reviewed the one case controlled trial that there is with ketamine and teenagers. What do we actually know? I mean, what is in the literature, even if it's limited?
Yeah, so I'm happy to talk about like just the editorial that we wrote, which was based on one of the studies for the adolescents that was conducted, and the trial had the participant age groups of like 13 to 17, and then ketamine was compared with midazolam for about like 40 minutes intravenous infusion. And then there was like measurements like within a few hours, like 1 hour, 3 hours, 4 hours or something, all the way up to 14 days. And there was just within the first day, as like Dr. Bromstead described, like there was like a rapid kind of like just the improvement in some amount of the depression. And that lasted till like 2 weeks, which is what the study period was. It was a small sample size, but still like just very significant kind of the findings, which is in line with what we have seen in the adult studies. And for the adults, we do know that there are approved formulations of the ketamine for the adults. And when I say adult versus like just the younger population, I'm just going by like 18 as a cutoff, just to make it simpler, that like 18 and above is, and 18 and below is like just somehow FDA and the approval pathways do tend to work. So what I mean by like approved is like it's approved for like 18 and above, and then under 18, that's when like just it still falls into the category of like being researched. And that's like one evidence of this particular study where we saw that like there was significant amount of the improvement in both suicidal ideation as well as like just the depression, but the focus was like depression assessment. And with like very minimal kind of the side effects. There was some amount of the dissociative side effects that was reported, and some hemodynamic, meaning like just some blood pressure kind of the instability, which was like just very short period of time, but like then it all resolved. So like safety wise also, this particular study, even though it's a small patient group, it had like just very good safety kind of the profile also. So that's really like one study that we have for the adolescents, which was conducted in a manner that like we probably may want to like conduct the research. And if there is any way to like just really on a larger scale, or even when like clinicians are like just already using it, when Dr. Braunstein, as he mentioned that like in his clinic, there are people who have already like just really on the where he would make a decision that like this person should get ketamine. Is there any way that we can use that data also in a larger kind of the evidence medicine based kind of like just the evidence generation? Because that evidence is important. If it has been tried already, even if the person was not part of the clinical trial or something, it's very important that like we continue to like just talk about it, publish it, and so that so that everybody becomes like aware of like just kind of the uses and like what the benefits could be. And then I did like just I've continuously just looked at the literature about the ketamine for like just the years now, but most recently, even for this webinar, I searched, and there are a couple of studies that are ongoing still, or like going to happen. But 2 or 3 studies is the maximum that like I can think of for the under 18 kind of the population. And usual formulations are either intravenous route, or it's like intranasal, which is like kind of like just one of the treatments which is approved for the intranasal spray. So those 2 are like kind of the major formulations that come to our way, and that's what we continue to see being studied also.
Okay, thank you.
I just want to say one thing, because something Mark said struck me. So we sort of think about these psychopharmacological, let's just whatever medication that, broadly speaking, and psychotherapy, which I very, very much agree with. But one of the things is that for me, children or adolescents or patients are not a variable annuity. It's not like, okay, this is how I continue to make money through talk psychotherapy. My problem with a lot of traditional talk psychotherapy for some of the conditions like suicidality is that talking to me about how to ride a bicycle is never going to teach me how to ride a bicycle. In order to ride a bicycle, I have to get on the bicycle. So I think that some of the psychopharmacological interventions paired with some of the psychotherapy, and I'm a psychotherapist, have to be targeted at what the person brings into therapy. It's like, I want to learn how to live life. I want to learn how to be less suicidal. So if we think about this as a skills deficit that people don't know how, they want to get better. And so when I hear colleagues who say, well, I just sit there and listen to my patients, that's wonderful. Please listen to your patients, but you also have to teach them something. So pair these things together and just be, with teaching how. Because not everybody knows how. I mean, I don't know lots of things, and so the only way to learn is to do so. So just a kind of therapy ought to be one that is for especially suicidal patients. Once you target from a psychopharm the suicidality in terms of like ketamine and TMS and some of the things, bring that down. But the talk therapy also like behavioral activation and other things like that.
Do you see then utilizing a model of ketamine for adolescents specifically as part of an integrated system, as almost a necessity?
Yeah, so here's the thing: I always try to go from least invasive and restrictive to more. Like, I mean, somebody is extremely going to act on suicidality. And by the way, one of the greatest recent tragedies is the New York Times, with good intention but terrible outcome, was putting a story about pro-suicide websites and the kinds of stuff that you can do to complete suicide, and people being able to order some very toxic chemicals online. So I've seen a lot of patients sort of heading in that direction, saying, oh, great, now I can find all the stuff that's pretty toxic. But getting back to your question is that if I can help people shift their course of despair, dissatisfaction with life, hopelessness, through validation and through behavioral activation, Zen, mindfulness, that would be my first step. If they have that acute suicidality, and by the way, the Lancet did a meta-analysis on all antidepressants in children and adolescents. And here's the thing is, they show that they do not work, in part because placebo is so high in children and adolescents. You get 70% response to placebo. And so when you get 70% response to antidepressants, there's not that much differentiation. But you tell kids this is going to work, and then 6 weeks later, they're still not working. So I think we need more acute interventions in terms of psychopharmacology. So if I'm not getting it through the behavioral techniques and psychotherapy that I'm doing, then I'll want to add an agent. You know, if it's truly a vegetative depression, I will consider an antidepressant. But I do want to also think very quickly about ketamine, TMS, and other alternatives. Because certainly 23 years at Harvard and at McLean have not shown me that traditional psychopharmacology for despair that teens are talking about. I'm not talking about bipolar disorder or psychotic disorders. I'm talking about this kind of despair has worked. Certainly not in my practice, seeing thousands and thousands of teens.
That's a great point. Mark, I guess one concern that has been mentioned pretty publicly about using ketamine for adolescents would be like a potential of adverse effects, right? So either addiction or long-term consequences. In your experience, Mark, have you noticed any downsides, or is there any way that you try to mitigate any risks for giving, this developing brain ketamine? What's your opinion and experience?
I think that this is a fine line that we have to walk in psychiatry, not just with ketamine, but also with benzodiazepines, with stimulants, right? Those are also medications that can be addictive that we prescribe a lot of. So I think it's something that we already do well in psychiatry, is kind of pay attention in the back of our minds to the addictive properties of certain medications before we prescribe them. I think as in general, we're probably much more conservative with our prescribing of ketamine than we are with benzodiazepines or stimulants, which we prescribe pretty freely without thinking about the long-term consequences maybe. So while I think we do have to use this, you have to think about everything as a risk and benefit of treatment. And so is there a possible risk of long-term addiction with ketamine? Yeah, but is the benefit for their acute suicidality, does it outweigh that risk? And have I actually seen anyone go? I haven't seen any children or adolescents go from the clinic to the street. I have seen that in adults that have figured, oh, I don't need to see the doctor for this. I can do this on my own. But I think like anything else, it's having an open dialogue with your patient, discussing this with them, letting them know about the addictive properties, but also changing the paradigm maybe of how they think about drugs of abuse, so that actually this medication, it's medicine, it's not a drug. And you're going to take medicine with having respect to the medicine, respect to yourself, and giving this as a gift to yourself to improve and make you well, not something you're putting in to hurt yourself, right? So it's actually another intervention that we can get into them about changing the paradigm of how they look at drugs versus medicines, and how to use these chemicals and molecules respectfully instead of recklessly. So I think it's a great question, and it's a really great opportunity, not just to have a discussion about the dangers of the risks of ketamine and abuse, but really to kind of talk about drugs with them in a new manner, and have more of an open discussion. So hopefully reducing addictions across the board with this.
Mm-hmm. Yeah, no, that's an excellent point. I know, Tapan, you've referred people for ketamine before, though you haven't used it yourself. What limitations do you see in the way that things are currently being practiced in the U.S. that's going to prevent teenagers or adolescents from receiving ketamine or starting, getting connected to this this different way of sort of conceptualizing health?
Yeah, I just feel that like and we can argue that like which way like just and this is what I'm going to tell is like just that's just how like just the evidence-based medicine and like just how things are getting prescribed usually like it's being prescribed in any of like just the large children's hospitals across the country, that like there is a standard kind of the practice of like, and this is not even about like just the psychiatric medications in general, that like when we have like just a kind of the indication or like FDA indication, like that's like one of the important things. When we have for the adults, even then we get like just a lot of kind of the faith that we can extrapolate a lot of the data from the adults, apply those into the adolescent populations, and still kind of assume that like it's going to be beneficial. So, and that's how I feel about ketamine. That I do feel that like we do have a lot of adult data for 18 and above. We have limited studies for under 18, but there are lots of evidences to suggest that like that like there is significant amount of like efficacy in suicidal ideation as well as depression. The largest barrier is going to be that like, I mean, you wouldn't, I mean, unless you go to a center which is specifically going to be tailored to like just the needs of like, I want to get ketamine, and like, is it a good thing for me, and in a controlled kind of the setting in any clinic, which is more and large, like it's right now in like community kind of like just the centers, but in a larger and like academic and like just kind of those frameworks, the largest barrier is just going to be like some amount of like just the evidence. And I really feel that like everything that we are hearing right now, that's all evidence. It just has to be like I would love to like just continue to see that like coming to like just kind of like just the mainstream kind of the journals as well as like just the literature, and that would just lead to larger access, because there is just like this standard practice, and we can that can be like a whole different kind of like just the discussion point that how evidence-based medicine should be and like how medical schools should be teaching. It's a whole different kind of the discussion, but like in the current framework, that's the largest barrier I can see, that we're not going to like to see it. And I feel that I'm somebody like who has been like just still in favor for some of the cases that like we and my views might change over the period of like the decades of practice, and I'm an early career psychiatrist, and at least in my kind of like just the clinical work, we do see significant amount of the response with like just what we are calling like just the largest evidence. Not everybody does, but like just a large amount of people, those who come to us, we do see significant amount of the benefits, and there are few who don't get benefit, and that's when like I do feel that it's worth trying. So do we want to like just continue to see that like it's being used because it has such a good efficacy? Then again, in one way or the other, and I don't mean that like the research and like so how clinical trials should be conducted has to be like so very rigid and not give like flexibility of like just listening to the kids, which is a great point. I really do appreciate hearing that like we have to listen to like what they are saying. If they are saying they are not getting better, we have to do something about it. Like if one after the other, if we keep trying things and if they don't work, that's just not serving them well. So we would probably want to like just elimination of the barriers, like in general. Mainly it's going to be like generating like just this kind of the evidence that okay, it works, and this is how it works, and we have seen for this many number of patients that it works, and then some amount of the studies that like, I mean, we might pass those barriers also, because like we're talking about like just the chemically something which is very different. So and any of the typical older kind of the medications which is working on serotonin, ketamine is not. Ketamine is working through glutamate. So how do we even like compare those two? So like I do see the point that like, do we want to even try some of the medications which are serotonin based versus like just completely different pathway which ketamine targets? So all of these are like just fascinating research points to me, that like, I mean, and again, there is a for some of us over here in the panel, this might not be a new news or like just new kind of like just the information, but like the real world evidence. Recently, like the FDA has like just released like some amount of like just the initial guidelines on like what do we mean by real world evidence? And real world evidence is like what we are actually seeing in the community, not in just the academic kind of the medical centers. And we are moving towards like probably like generating more of the real world evidence. And there are different ways and different statistical ways to look at the real world data. So even that can supplement in terms of breaking these barriers, that even if it's not done in a standardized academic kind of the setting research, even if it's done in real world kind of like just the clinics, there is a way to analyze, and there is a way to still publish, and there is a way to still continue to disseminate that information. So I know that was a long answer, but like that's how like I do see that barrier that like I would want to see evidence, and I'm hearing a lot of evidence, but like how do we put that into kind of the framework which would convince like anybody who is like just really practicing child and adolescent psychiatry.
Yeah, no, thank you for a very well thought out answer. I appreciate it. I'm mindful of the time, and we do actually have just a couple of questions that people have that I would like to try and get to. So one of them specifically for Dr. Bronstein is about your thoughts on counseling on the use of ketamine changes for those receiving it more than the initial 6 treatments. So I guess beyond that, what are your thoughts?
Totally. Yeah. It's a very different discussion that you have to have with someone with ongoing treatment versus that initial 6, because if you give that to them more long-standing, you're going to increase the risk of addiction and dependence. So you just want to have more of a discussion about that. You just want to have open dialogue with your patient about it. But yeah, to answer the question, definitely, it's a different discussion you have with someone with ongoing treatment versus just initial.
Thank you. Then there's one other one actually that goes along with that, Dr. Bronstein. What age is the youngest you might treat for suicidality with ketamine infusions under the appropriate circumstances?
The youngest that I've treated is 12, and I could see a case for younger. I mean, it's like, at what age would we think about giving someone Prozac? And you know, I think one of the main risks we worry about with the tolerability of ketamine is the psychedelic experience, if that is to occur. And from what I've heard from my colleagues and from what I've seen, there's actually the younger patients have an easier time with this than the adults, just because of the brain and how children see things, right? Children have a much more relatability to the psychedelic state and imagination than adults do.
It's a tragedy that we lose it over time, actually. You know, is that that mysticism of and the joy of youth is we lose that. And so I think that they're much more open. You know, just to that point, at a time, you know, we've seen a 300% increase in completed suicides in kids 10 to 12, at a time when antidepressants are one of the most prescribed drugs across all age groups in the United States. So what's it telling us is that we're either more depressed or that these things aren't working. But if we have such high rates of depression, high rates, 300% increase in young girls, 12 to 14, completed suicide, and we're prescribing so many medications. So what's this telling us? And by the way, here's the other thing is, you do have to follow the money. You know, it's there's a lot of, you know, people getting wealthy on a lot of these things. I also think something that Dr. Parikh said was, you know, a lot of my colleagues and our colleagues seem to me to practice what I would think of as defensive psychiatry, which is this idea that, you know, like, oh, this person's coming depressed, I have to put them on an antidepressant and I follow the standard of care. But fear cannot be our motivation for treatment. We have to get people better. And so when something doesn't work, it's okay, it doesn't work. And when you have honest dialogues with patients and their families, they appreciate it. I get the opposite, where lots of people coming in, they said, okay, I've tried all these serotonin reuptake inhibitors, all these SNRIs, all these mood stabilizers, all these antipsychotics, all these whatever it is, and they haven't worked. And you say, well, you know, maybe this is not depression, maybe this is something else, and let's look at some other ideas, but not be afraid of that. We cannot be afraid of standing up to the truth, because at the end of the day, you're going to live with yourself and the way that you've practiced medicine. Yeah.
Wonderful. One very last question to slip in, and we will end after this. It's seeing, you know, I guess it's looking forward. So it's a great last question. You know, in terms of getting patients, adolescents to have ketamine, does ketamine accessibility vary, you know, by state in the resource availability sense, also the legislative sense? Maybe Mark, if you want to take that as the last, and then we'll end after that.
No, I mean, the accessibility is pretty much consistent from state to state. There might be a couple outliers here and there as far as regulatory things go. But in general, I mean, I think the main problem with access to ketamine treatment is financial. And I think that's what we need to focus on to increase the accessibility is one, doctors prescribing it more to kids and adolescents, teenagers, and then B, getting insurance companies to pay for it.
Very similar to adults too, but for sure. Well, unfortunately, we do have to wrap up the conversation at this point, but I want to thank all our panelists so much for joining us here today. It's been an extremely fruitful discussion. And if anyone wants to say a closing remark about where you kind of see the future of adolescent mental health care, you're more than welcome to.
I have just one quick thing to say. Like, this was a wonderful discussion, and I appreciate hearing from everybody. And this is exactly what I suggest families: listen to everyone. Listen to like just what comes to your way. Different kinds of the views. Decide what you think is best for your child. Decide what you. I mean, and if you are 18 and above, like, decide for yourself what you think is best. Just gathering the information. This is something that I really encourage everybody that get the information, make the informed decision. Think about it. What do you want to do?
All right. Well, thank you so much. And thank you for all of our panelists here, Dr. Parikh, Dr. Aguirre, and Dr. Bronstein for being here today, and have a great rest of the day. And thank you for everyone that was watching and participating. And I hope you enjoyed.